For many, a cancer diagnosis turns life upside down. Suddenly, the focus shifts from everyday life to survival rates and treatment options. The inside of an oncology office becomes a normal part of life until one day when the cancer therapies work and the scans show up clean. But many people don't realize that surviving cancer isn't the end. Those same successful treatments, like radiation or chemotherapy, have likely created a new set of problems.
I've found, especially over the last few decades, that in these patients, we almost get a false sense of security that they're fully out of the woods. But we found out that that's not actually true when it comes to the heart and the overall cardiovascular system. We're finding that continuing to monitor these patients, depending on their cancer treatment and the cancer that they had, as well as their comorbidities or other chronic medical conditions that they had during their cancer, their risk of developing brand new heart disease is significantly increased compared to if they didn't have cancer and if they didn't receive any cancer treatment.
That's Dr. Chris Fine, an FACC cardiologist with National Jewish Health and Intermountain Healthcare. He says all types of cancer and treatments elevate a patient's risk even if they're otherwise healthy. Without occasional checkups, the cardiotoxicity or heart damage could build for decades until it's too late to save the patient.
If they were diagnosed with leukemia or lymphoma early in life, even in their 9, 10 years old up to 16 years old, they have highly effective treatments for cure. But these patients go to live normal lives, they graduate from their oncology office, and then we're finding out that they have significant calcifications on their heart arteries or their heart valves as early as their 30s or early 40s. And so if you see these people walking on the street or in clinic, you would have no idea that they're at a significantly elevated risk of having their very first heart attack before they're 50 years old, compared to if they never had cancer or never received that treatment.
A 2019 study in the European Heart Journal reports that more than 1 in 10 cancer survivors in the U.S. will die from cardiovascular disease. But a new medical field is working to change that. Cardio-oncology supervises patients' heart functioning while they receive cancer treatment. This new discipline invites cardiologists into cancer centers for the first time. At the moment, Fine is one of the few cardio-oncologists in the U.S. He says in the past, cardiologists didn't usually interact with cancer patients.
We didn't know how to intervene or when to intervene, what that intervention would even lead to, because there was always the stigma that a cardiologist evaluating a cancer patient, especially early on, would take chemo away or say that we couldn't use life-saving treatments, things like that.
When in reality, cardio-oncologists work with each patient to find the best treatment option for their cancer and their heart. Fine says the ultimate goal is to treat the cancer effectively without causing any issues down the road. Therapies like radiation can cause damage even decades after the initial exposure. But Fine says these issues aren't the focus when dealing with cancer, and leaving them on the back burner often leads to ignoring them altogether until it's too late.
We pivot our thinking during cancer treatment to solely 100% about the cancer, which is appropriate to some degree. But if we can have another provider that's in the patient's corner, that's not even in the background, really a part of the foreground with the patient, to help monitor their cardiovascular assessment throughout the treatment of their cancer, that significantly leads to consistent improvements in care on the short term and long term. But awareness for the patients as well, that this field exists, this is something that's important, and there may be a gap in their care depending on their risk if they don't have access to someone with formalized training or a formalized focus in the cardiovascular care of a cancer patient.
Fine says the first step in cardio-oncology assesses the patient's baseline risks. Do they have pre-existing conditions like high blood pressure or diabetes? Based on results, the doctor estimates their risk of developing heart damage during their cancer treatment.
The second stage would be what kind of treatment have they received in the past or are currently receiving or about to receive to further assess risk. That helps me identify the best way that we're going to be able to survey the patient or monitor things with coming to clinic just for a clinical assessment, certain types of imaging that we could do, like bread and butter EKGs or an ultrasound of the heart called an echocardiogram.
After the assessments, the cardio-oncologist continually monitors the patient's heart throughout their treatment journey. Fine says they want to identify any damage early so that they can intervene before it begins to affect the patient.
And the reason why that is important is if clinical cardiotoxicity occurs, there's almost always at least a pause or interruption in their cancer treatment. As we treat the cardiotoxicity and hopefully resolve it to the point where it's safe, again, to reinitiate their cancer treatment, every time cancer treatment is paused or interrupted leads to a worse outcome for the patient.
Fine believes the risk of treatment interruption would lower drastically with an in-house cardio-oncologist. The multidisciplinary care can help keep patients on track without disrupting their cancer therapy. Unfortunately, cardio-oncology is still somewhat of a secret, even in the medical world.
We're being severely underutilized. Most people, when I meet them for the first time in clinic, they've never heard of this particular discipline or niche of cardiology or oncology. And that's fairly universal with patients as well as providers. They just don't know what services you can offer, to be honest, and how you could benefit the care of their patient and how you would do something different compared to what they're already doing.
However, a cardio-oncologist is much different than a regular cardiologist. These doctors are trained specifically in how cancer and therapies affect cardiovascular health.
Since this field is rapidly growing, it's hard for a general oncologist or a general cardiologist to really keep up. Both fields are getting more advanced and more sophisticated with more and more nuance all the time. And it's nice to have somebody in the patient's corner who could speak the language of both providers and really bridge the gap to multidisciplinary care.
Fine says the field has rapidly grown in the last 5 years. More medical programs are offering formalized training and fellowships specific to cardio-oncology. He says the goal is for cancer patients to have a team of doctors able to monitor different aspects of their health, so that when they beat cancer, their battle is over. You can find more information about Dr. Chris Fine and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Twitter, and Instagram. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Nancy Benson. Coming up next week on Radio Health Journal.
There are more fish consumption advisories for mercury than all other contaminants combined.
Do you know how dangerous mercury really is?
Then how scientists are utilizing the placebo effect.
Maybe we should look at placebo not as a problem, but as a resource. Because in a lot of clinical trials, placebo is the scary monster.
All that and more on Radio Health Journal. I'm Reed Pence, the producer and host of Radio Health Journal. If you like listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
The refugee resettlement program in this country expects refugees to achieve self-sufficiency within 90 days.
The immense challenges of building a new life in an unfamiliar place. Then,
the scale of sugar production, the scale of these land estates that we call plantations was vastly ramped up, and that enslavement became, for the first time in European history, entirely racialized.
The untold narrative of early European exploitation. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Radio Health Journal and Viewpoints on your favorite radio station. And subscribe and listen anytime on Apple Podcasts, Google Play, and Spotify. Also, follow us on Instagram and Twitter at Radio Health Journal.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.